Hi, my name is Dr. Ed Shahady. I'm from Fernandina Beach, Florida, and we're here at the Cardiometabolic Risk Conference in Las Vegas, Nevada. I'm joined here by Dr. Virgil Brown, who's an Emeritus Professor at Emory, and also have with us today Dr. Peter Jones from Baylor. He's a Professor of Medicine there, and he runs our lipid clinic. Welcome, gentlemen. Appreciate your being here. We're really honored because you guys are sort of some giants in the field of lipidology with us, especially Virgil. You're the founding editor of the the Journal of Clinical Lipidology, and 9 years, I think that journal.
We're completing 9 years now, yeah. And
excellent.
it's growing and every year.
Excellent. Really a great addition to the literature.
Someone's cell phone just went off.
It dinged. That must be yours.
Oh,
You need to silence it.
Can I get you all to start over,
you heard a phone?
please?
Mine's over there, so I'm okay.
Gosh.
Or
Okay.
start pick up wherever before the phone went off.
Isn't that amazing? I didn't hear it at all. Come on. This protective case makes it really hard
very
to push
hard.
that
Makes it harder. Makes it harder.
Okay. Sorry.
Okay, no problem. Well, I'd like to start off asking you, Virgil, about something you talked about today in your presentation. And that's the current controversy about should we have a target for LDL? And of course, the new ACC/AHA guidelines don't recommend that. So how do you feel about that?
Well, I think people are misusing the word target.
Okay,
LDL is the target.
okay,
Blood pressure is the target.
okay.
Non-HDL cholesterol in the NLA parlance is the target.
What's non-HDL? Define that for us.
Non-HDL is everything but HDL, all the cholesterol and all the lipoproteins other than HDL.
And we calculate it by how?
Simply measuring total cholesterol and subtracting the HDL cholesterol.
And you have that.
Couldn't be simpler.
Couldn't be simpler. Okay.
But if you don't put it on the lab report, we found that people forget about it.
Absolutely.
And so we've been fighting that. We've been
Right.
trying to get the labs to actually report it.
Right.
Because physicians forget to calculate it.
Right. So what do I do as a clinician? I obviously I have to order LDL to make the diagnosis, but then do I just forget about it? Don't order it anymore?
Well, one has misinterpreted the American College of Cardiology guidelines in that way,
Right.
that you only need to decide about treatment based on the original measurement.
Right.
That is not what they say in the guidelines, although the tables sort of give you that
Right.
impression.
Right.
Now, I think the problem, first of all, let me just say that these American College of Cardiology, American Heart Association guidelines have some very good points.
Right.
They point out that traditionally in America, even though we treat a lot of people with
Right.
statins, more than 50% of people with elevated cholesterol who are over 50 have
Right.
are on statins,
Right.
but they're on low doses. And we know from all of our trials that if you push the dose, you gain additional
Sure.
record of safety, and the risk goes down. And so they have emphasized choosing a high dose of statin, as high as a patient
Right.
will tolerate.
Right.
And they emphasize also looking at the patient and deciding whether this is likely
Right.
to be a very tolerant patient.
Uh-huh.
They've been concerned about older people for that
Right.
very reason.
Right.
And all those are good things. No one argues with that. The problem is when you read the guidelines and you talk to the people who put them together, they are calling the goal the target.
Uh-huh.
And the reason that is improper, first off, is not the way the term was used. Secondly, when you say a target, you're trying to hit one thing, a singularity, right?
Right.
And they'll say, you can't just titrate to 100. That's not good. That's exactly right. That's why we've used the term goals.
Uh-huh.
And goals are not one number.
Right.
They never have been.
Right.
They have been written in the oldest of the version of guidelines that
Right.
says less than some number.
Right.
That means lower than.
Lower
the
than,
number,
right.
And so you have your full range of values
Right.
below 100 or
Right.
below 70.
Right.
And any of those are okay, but the lower the better.
Right.
And it makes lower the better make more
Sure.
sense in the guidelines. If you say, when we say goal, we're talking about the very upper limit of
Right.
where we want this patient to operate
All
in
right.
terms of their LDL value for the rest
Right.
of their lives.
Okay.
And so we think that's a very important point. that
Well,
we should emphasize.
National Lipid Association does recommend goals.
Yes,
You want to mention
absolutely.
what they are?
Yeah, we feel that if you're going to put anyone on a statin, the minimum goal should be to get them under 100 milligrams per deciliter for their LDL.
Okay.
And under 130 as a minimum value for their non-HDL cholesterol.
Right.
It should be under those two numbers. And we can all debate about how low you take a given patient.
Right.
And that's going to have to do with what it costs you,
Sure.
what they are able to tolerate, how high their risk, a variety of things that enter into deciding whether you are far enough below the goal parameter.
Right.
I like to think of treating lipids as like basketball. You know, you don't just hit the top of the goal and have it bounce off.
Right.
You hit the goal, the target, which was it's got to go into the goal and drop on the floor to be a score, right? And that's what we're trying to achieve with lipid reduction.
Okay, excellent. Dr. Jones, Peter, let's ask you about, because you just gave a talk on this. You know, one of my frustrations as a clinician, as my patients get older, what do I do? Like if they get to 80, do I stop, statin medicine? Do I look at my older patients different? Would you like to comment on that?
Well, yeah, there's two situations here. One is deciding on initiating a statin in an older person.
Okay.
And the other is continuation of statins as people age.
Right.
The first one is initiation of statin use. And I think there's secondary prevention and there's primary prevention.
Right.
Most of the guidelines, including the ACC/AHA as well as the National Lipid Association, have no age range on initiation of statins for secondary prevention.
Right.
If you had a bypass, PCI, and you're 82 years old, if they're doing bypasses and angioplasties on an 82, you deserve a short-term and probably longer-term risk reduction strategy.
Right.
So statins should be initiated. Continuation of statins in patients who've had established events as they age.
Right.
If their quality of life and competing comorbidities are reasonable, then yes, you should probably continue a statin indefinitely in secondary prevention as a person ages. Primary prevention initiation, not much data there. Over the age of 75 or 80, it's very difficult. And I think the NLA, National Lipid Association, does recommend to consider risk evaluation.
Right.
We put a higher level of risk calculation in older individuals for initiation, greater than 15% on the pooled risk cohort.
Okay.
And we even suggested maybe coronary calcium can be one of those screening tests that if an older person has very low coronary calcium, that they're at a low risk for coronary events for their age, maybe they don't need a statin. If they have a lot of calcium, they definitely need it.
What's a lot of calcium? What number?
Well, the minimum would be more than 100.
More than 100.
And when you get more than 300, your risk really does get to be very high for a future coronary event. Now, the other side of the coin is besides initiation and continuation of statins are withdrawal of statins. And I get those questions a lot. Is it reasonable at a certain age to stop a statin?
Right.
And I think there was a very pragmatic study that was published just this year in the Journal of JAMA Internal Medicine, where they looked at people who had either cognitive issues as part of their near end of life problems, and some had cancer. And they randomized them to either continue taking a statin or to stop it. And the question was, does stopping a statin enhance a bad outcome?
Right.
Because there was always this concern, maybe if I stop a statin, I'll increase my risk for stroke or increase my risk for a heart attack.
Right.
What they found is that whether you continued or stopped the statin, their end-of-life issues over the next year were driven more by the other disease problems and issues they had. And either taking the statin or stopping the statin made no difference in cardiovascular contribution. So you can have those decisions with patients when life expectancy or end-of-life issues come there. It is reasonable to consider stopping the statin.
Well, you mentioned about cognitive issues, and that's one of the things that the lay press, patients certainly ask us, or they tell us, it's influencing me cognitively. Is that real, or is that just an association?
It's a great question. I'm going to give you my impression. I'll see what Virgil wants to say as well. But I will say that as much as we can tell in randomized clinical trials, statins do not seem to change dementia risk.
Right.
So they don't make it better.
Right.
And they don't make it worse. There's actually been 2 trials where statins have been used versus placebo in people with documented early cognitive issues. They were randomized for 2 years with neuropsychological, very specific testing to
Right.
see if they could change the rate of progression
Right.
of decline.
Right.
It didn't make any difference taking a statin or taking placebo. So what I tell patients is, I cannot tell you that a statin will worsen your cognition, but unfortunately I can't tell you that taking a statin will improve it either.
Right.
I can tell you it'll reduce your risk of a stroke,
Yeah.
but I can't tell you that it will change your general sense of cognition one way or the other.
Okay. What do you think, Virgil?
Yeah, I agree. I think, I was the chairman of the Data and Safety Monitoring Committee for the PROSPER trial, and these were people who were over 72 years of age, up to 80, when they entered, and there were 6,000 patients in this trial, and there was a great effort to document changes in memory and cognition.
Right.
MRIs were done in 800 of those patients at the baseline and at the end, and again, it was placebo-controlled with pravastatin 40 milligrams a day. No change whatsoever could be documented in the pravastatin treated group versus the placebo treated group.
Right.
This was a 4-year study, 3.5 to 4 years. So we don't have any really believable evidence that statins can prevent a problem with cognition unless they have a stroke.
Right.
But on the other hand, we have, I don't believe there's any believable evidence that it can cause cognition failures.
Right.
The problem is, of course, we're treating a lot of older people now,
Right.
and they're going through this period in their
Sure,
lives where
absolutely.
there's a high probability of them having a problem with cognition. So, we suffer this always with chronic therapy, that people begin to blame the natural course of life on whatever you're doing. I mean, insulin has been blamed for all sorts of things over the years. And the same is true with statins.
Absolutely. Well, I have 3 members of a family with familial hypercholesterolemia. Mother's about 50, daughters are college age. They all swear that, they have cognition problems. Can't study. She happens to be a dentist, and then they say they stop their statin and the cognition problems go away. So how do I handle that?
Well, a belief system sometimes is very hard to invade and conquer. And and that's true of all sorts of belief systems. I think one of the things you can do is be sympathetic and empathetic with the patient. They have a problem that is worrying them. You can't deny the problem.
Right.
So, you try different things. And I think one is to try a water-soluble statin. We know that there are certain statins that go into the brain of animals, and those have been shown to be true. Like simvastatin goes into the brains of rats, whereas pravastatin doesn't.
Right.
No one has ever been able to show that there is a cognition difference between those two drugs or a sleep disorder difference. And those have been pretty well studied.
Right.
So, however, the patient may believe it.
Yeah.
And, if you can get them to take a cardioprotective drug and stop blaming that drug for their problems, that is a huge gain for that patient.
I agree. Trying a different statin, lower doses, every other day dosing.
Right.
There's still benefit to taking a very important drug like a statin, particularly those with familial hypercholesterolemia. Using non-statin drugs is also very important that we know don't have any cognitive effects.
Right.
But I've had to work a little bit with finding a regimen that a patient will tolerate, but amazingly, you can find one.
Yeah.
And they will
Keep working with them. So good suggestion. And that's true of myopathy too. So you take any patient, perception is reality. We need to work with patients, change medications, maybe give them a little vacation, go back.
Absolutely.
Absolutely. So great. Gentlemen, this was great. I appreciate that. Thanks for being here, Virgil. Thanks for being here, Peter.
Thank you very much.